Hello my dear friends. Our topic for presentation today is surgical audit. So from this picture you can see that surgical audit is something in which all the surgeons sit together and discuss. Sometimes when we look ourselves in the mirror, we say that we are some bit of obese or we have put on some fat, and sometimes we feel that we should improve. Then we see some pictures of a gym guy or a very gym video, then we'll feel like we should work it out, we should improve ourselves. And sometimes we may work and turn our previous obese stage into a better body shape. We may not reach up to the picture, but that is fine. We'll work to a better body shape. So exactly this, when this happens in a surgery department, when this happens in a surgery unit, when we evaluate our strengths, when we look into ourselves of a surgery unit, how we are performing surgery, what are our complication rate, and then when we are improving into something better, it is called surgical audit. So in this case, suppose we can see what is the OT like. Can we improve the lighting? Can we improve the anesthesia techniques? Can we improve the instruments? And finally, when we improve into something better, that is the basic role or the basic purpose of surgical audit. And finally, it will benefit the patient. So, the definition, surgical audit is a systematic critical analysis of the quality of surgical care that is reviewed by peers against explicit criteria or recognized standards and then used to further inform and improve surgical practice with the ultimate goal of improving the quality of care for the patients. So, to improve ourselves for the quality care for the patients. So, it is reviewed by peers. Okay, peers means our friends or our surgical community. Okay. So, there are certain terms when we come to surgical audit like service evaluation, research and surgical audit, which is sometimes used interchangeably. So, it is confusing. So, let us understand what it is. When we are looking ourselves, when we are looking what are the cases which are done in the department, what is our complication rate, what is our bed strength, when we evaluate ourselves, it is called service evaluation. And when we compare it with the international standards or the local standards or the specialty standards of others, then it is called a surgical audit. Sometimes we feel that the international standards may not be beneficial, may not be applicable in our scenario. We have to do something different. We have to find something different which can be applicable in the scenario. So we will see which type of exercise is better for our abs or our abdominal muscles. Like that, we see which type of procedure or which type of process is better for our surgery department or our unit. So for that, we may need some kind of a research. In this way, service evaluation and surgical audit can finally lead on to a research. So what are we going to audit? The audit can be either the structure of the department, the structure of the theater, the structure of our instruments, anything. Or it can be, we can audit the process, how the patient, the process of how the patient is brought from the casualty to the theater, or how the patient is taken from the elective admission ward to anesthesia to the theater. And finally, we can evaluate our outcome, what is our complication rate, what is our mortality. So anything, any part in the surgical body you can audit. Okay. Now, what are the steps of the surgical audit? We have to determine the scope of our audit. Then we have to select standards. Then we have to collect the data required for the audit, present and interpret and peer review the results, and finally make changes and monitor progress. And again, we have to regularly audit in a monthly or yearly or 6 monthly or quarterly intervals. So what is meant by determining the scope of the audit? It means that We should not bite off more than we can chew. We should not initially try to audit the complete surgeries in the hospital. I am going to audit all the procedures done by plastic, neuro, gastro, uro, every surgeries in the hospital. If we are trying to audit initially itself, it will be a failure. First, we should start with small price. First, we should try to audit our unit only. A particular surgery we can audit, or an outcome of a particular surgery we can audit. So, if we audit like that, then once we know how to audit, then we can go in for a bigger auditing procedures. So we should see what we can chew, what is feasible for us, what we have, what ability we have to do in our case scenario, in our auditing system or our auditing capability, and then based on that we have to go for determine the scope of the audit. Now again, suppose these are the different departments in the hospital. So how what are the different scopes? These are the different departments in the hospital, and each spike represents a type of surgery in one of the in each department. Suppose onco surgery department is doing this much number of surgeries or this much types of surgeries. When we do audit for all those surgeries in all those departments, it is called a total practice or workload audit. We can decrease the scope again. Suppose we are auditing the specialty, one general surgery only, then it is called a specialty audit. It can be either done in the hospital alone or it can be done along with other hospitals, that depending upon the scope. So that is how we determine the scope. And again, we can decrease the scope further by, suppose we know that in general surgery there are different units, maybe S1 to S6 for each weekdays. So if we are auditing the surgery of one unit, then it is called a clinical unit audit. Again, suppose not necessarily we can audit one surgery also. That is called a selected audit. In a department, if we are auditing only one surgery in all the units, it is called a selected audit. Again, we can further decrease the audit. Suppose we select a surgery and we select one part of it, it is called a focused audit. This one part can be either intraoperative complications, post-operative complications, in-hospital death, anything, or length of the hospital stay. So when we focus our audit into one surgery, into one part of the surgery, it is called a focused audit. We can choose any of these audits for our purpose. Next comes the select standards. Select standards, we know we can see, which are the standards we look into when we do a surgical audit. We can use evidence-based research guidelines or adapt to the existing local guidelines or look into your specialty group to define the standards. So how will we take an evidence-based research guidelines? Suppose I am doing thyroidectomy and I am having an incidence of a complication of recurrent laryngeal nerve for a few cases. So I am searching to see whether these for the international standards. I am searching recurrent laryngeal nerve palsy incidence scholarly articles. Then I will get a lot of articles regarding the recurrent laryngeal nerve palsy in Google Scholar. And then one I will take. Say suppose I will check for a few. Suppose I am taking this paper by Elsevier in 2005 and I am clicking on it, then I will find that the overall incidence of temporary and permanent recurrent laryngeal palsy was 5.1% and 0.9% respectively. So I get an idea about, I have to search for multiple papers like this and get an idea about the international standards of regarding the recurrent laryngeal nerve palsy. Then when we compare it with our recurrent laryngeal nerve palsy injury in thyroidectomy, then we know where we stand actually. That is the selecting the standards happening based on the evidence-based international criteria. Next, in surgical clubs and all, we can look to your specialty group to define standards. In surgical clubs, different people, different surgeons from different hospitals will present their complication rates and their surgeries. Then we can understand what is their complication, and based on that we can define our standards. So next method is we can adapt existing local guidelines for local relevance. Suppose we can see what is happening in the other units of our surgery units, what is their complication, right? And based on that, we can understand where we stand. So this is the method by which, these are the different methods by which we select the standards, either evidence-based, local guidelines, or look into the specialty group. Now, what is the next step? Next step is collect the data. You have a proper data entry system, either in the case sheet, in the computer, in the case sheet in written form, or in the computers or special forms for that. So we have to have a proper data entry system in the hospital. Then only we can collect that data. So what all data will be collect? For to evaluate surgery, we have to have a minimum data set, which include the name, ID, age, sex, diagnosis, admission date, discharge date, operation category, procedure, and complications, discharge outcomes, and the surgeon. So all this is a minimum data set which have to be there to audit a surgery. There can be advanced, we can have an expanded set for that, like admission types, whether there was comorbidity, what was the presenting problems, what was the final diagnosis, what was the ASA grading, what was the wound infection, type of anesthetics, admission outcome, follow-up outcome. These are the expanded data for a more effective audit. But for that, the data entry system for all this should be proper to collect that data. Suppose we are studying a particular part of surgery or a specific part of surgery, we can have additional data. Depending upon our study, we can see which are the clinical indicators and put on the additional data. So this data can be either collected in a prospective manner or a retrospective manner or a both. Either can be prospective manner or retrospective manner, or can be a longitudinal manner. Next is we have to present, interpret, and peer review results. It has to be a cordial, a friendly atmosphere where there is adequate, where there is privacy, and we should sit together. The surgeons concerned, we don't need to have a crowd. There should be at least minimum 3 surgeons, and we should peer review results. It can be a bit more larger group like this, where some of the juniors will present and the others can all together evaluate. So we have to understand that peer review is a learning exercise. It is not an opportunity to blame or brag the patient. Suppose one surgeon's complication rate is high, everybody should not blame that surgeon. Or suppose one surgeon's results are good, he should not brag about the results. So peer review has to be in a very good atmosphere. So it is like a family discussing. It is like a family discussing their problems along with both the senior faculty and the junior faculty. Maybe there may be senior surgeons, there will be junior surgeons. It is like a family discussing their problems out and finding the results. And finally, the head of the family, the chair will come with a format, reporting format. Suppose everybody are equals, then the chair can, for each audit, the chair can change. So we have to identify the issue. We have to identify what is the effect on the host patient and hospital. So say the issue is recurrent laryngeal nerve palsy during thyroidectomy. Effect on the patient and hospital is there is higher amount of litigation and the patient is having problems. Recommendation is we should not use cautery during dissection of recurrent laryngeal nerve. And what action should be taken by whom and when during the time of surgery. We have to identify the surgeon who is having higher amount of complication, and the action has to be taken by him, and the final outcome and the report should be evaluated. So this is the chair report for format, where the head of the family decides on what action should be taken based on the problem. Now the next is make changes and monitor progress. So when is the best time to do this follow-up? Should we do it immediately or should we do it delayed? That will depend upon what is the problem and when is the result happening. That will change from procedure to procedure, that will change from surgery to surgery, that will change from hospital to hospital. So based on what is the problem and how much approximate time will be taken to resolve the issue, we have to do the follow-up. And how will you do the follow-up? Sometimes we have to only look for relevant parts. Sometimes we may have to do a repeat audit to see whether the follow-up is effective. Now, what makes for an effective audit? We have said that it is like a family discussing their problems. So there should be a promotion of a culture of audit. That means the department should sit together once in a month and discuss their problems. So there should be, and for that we should allocate time and resources for that. And we have to oversee and verify data collection. We have to see that there are no big holes in data collection, and for that we have to make sure that the data entry system is proper. So we have to oversee and verify data collection, and finally there should be a productive peer review for an effective audit. All these are happy auditing things, but audit is not always very happy. There is sometimes there can be a dark side to it. How? Audit should have very much of a privacy, because sometimes there can be a higher mortality for a surgeon. There can be sometimes mistakes by a surgeon. So whenever there is an audit, the data should be confidential and it should be like a confession. There should be the data. There should be absolute privacy. If there is, we are not trustworthy. We are giving the data which should be in the family to other people, there can be problems. That is one part of surgical audit. Next is the surgical audit is supposed to be in a scenario where uh, where we can address the problem of a person, where address we can the other surgeons can help the problem of this surgeon or the affected surgeon. If it becomes a blame game, then when they are pointing fingers, your results are not, you did that mistake, so that is why the patient died. That if it becomes a blame game, the total spirit of the audit will become very bad. Sometimes this happens in the mortality conferences when there is a very high amount of blame game, and this sometimes and because of these reasons, they may walk away. There will be walk away, there will be diverses, there will be no more communication between the different units. Like that it can happen. So many times the department will be happy, each one will mind their own business, and there will not be any much of an audit. So instead of being a happy family, they will become detached. So but it is anyway better than this blame game and diverse. But for the department to function effectively and be like a happy family, it is better to have a good amount of profitable discussion. So this walk away and problems happens when it is the senior surgeons. What about the junior surgeons? Many a times, ideally, when the juniors makes problems or when their results are poor, there should be a loving, or there should be a caring uh, advice or a caring correctional methods taken by the seniors in the group or seniors in the peer review. That is a very good atmosphere. This is the ideal atmosphere which we like. But sometimes what happens is the junior, even though the senior is trying to help, the junior is not ready to hear. He will be kind of stubborn. And sometimes what happens is the senior will be so aggressive to the juniors. So the other peers will be so aggressive to the junior surgeons, though they will lose all interest. And sometimes what happens is when the scenarios like that happen, ideally when the juniors are underperforming, or ideally when the smaller surgeons or the smaller peers are underperforming, they may have to get reprimanded, or they may have to keep away from that surgery, or they may have to retrain in that surgery, or they may have to avoid take some steps or take some skill training programs to avoid that complication. But if this other senior surgeons are so predominating, it will happen like it will be like a child abuse for the junior surgeons, and many a times they leave the place. They leave the place being fed up. So it is always better to maintain a loving scenario or a caring scenario in case of an audit for the junior people. So this comes in this part what we have discussed in like a family issue. This comes in the audit complaints. So suppose where the audit uh, identifies one person as an outlier, that is, he is not uh, getting in the results which are expected, or he is having more complications. So the audit monitoring committee notifies the member that this your results are poor, or you are having a higher complication rate. Then so suppose there may be some doubt that it will be a problem with the collection of the data. So the audit monitoring committee will again review the data which is collected, and based on that it will tell the surgeon to temporarily halt the procedure, take a retraining, and then go for the surgery again. So this is, it will be like that, where the audit monitoring committee will tell the surgeon to be a good boy. Suppose the surgeon is not hearing this. Surgeon does not want to stop the procedure, performing the procedure. He is going along with this. Then the audit monitoring committee will have to take sufficient action to prevent the surgeon from doing the procedure for which he has a high complication rate. So in brief, we can determine the scope of the procedure. We should only chew what we can chew. We should select the standards, evidence-based international standards or local standards. We should collect data, the minimum data, the advanced data, or the specific data. We should present and interpret and peer review results. The peer reviewing of a results is like a family meeting, whether everyone should be caring. It is not a blame game, it is a learning exercise. And finally, we should make changes and monitor progress. So this is regarding the surgical audit. So let our surgical department culture of surgical audit. So that is regarding surgical audit. Thank you.